Hi, my name is Connor Weiss, and I'm an exercise science major at Westchester University. I just wanted to give a disclaimer that unfortunately, because my laptop is kind of causing me problems, I have to use this mic and this headset um, for this presentation, but it should not be an issue whatsoever. Now, I wanted to talk about why I chose muscular dystrophy as my presentation topic. I have a family member, a cousin actually, who was diagnosed and is suffering from muscular dystrophy. Fortunately for him, he is in his late 20s and has been able to manage all the signs, the symptoms, and all the factors that we'll get into later about this debilitating and unfortunate disease. So now let's talk about what muscular dystrophy is. It's characterized and defined by a group of genetic diseases that cause progressive weakness and loss of muscle mass. And this is caused specifically by the DMD, gene being mutated, which is found on the X chromosome. This gene is responsible for the production of dystrophin, which is a protein found in muscular skeletal cells that play the role in keeping the muscle's structural integrity and allowing for nutrients to be able to repair the muscle when it's broken down during things like exercise and activities of daily living. Um, it it's most common in males, and it's about 1 in 3,500 births in the United States, and it's currently affected about 250,000 lives. So now we'll get into the signs and symptoms. As you can see here, um, muscular dystrophy can be observed really by the naked eye or specifically diagnosed with a muscle biopsy. Now, these signs and symptoms begin at early ages, around 5 to 8 years old, and really take full effect by the time the male reaches puberty. And at that point, unfortunately, their muscles are so atrophied and so disformed and disoriented that it compromises their integrity to walk, and they end up needing to be in a wheelchair for the remainder of their lives. Um, some of the symptoms and signs are chronic muscle fatigue, tight Achilles, as you can see in the previous picture down here. You can see that as the disease progresses and everything, um, the males tend to have more um, pronation, walk more on their toes, and have their Achilles tighten up, and their heel cord tighten up to the point where they're forced to hunch forward and walk on their toes. Now, this doesn't just affect muscles in the limbs, it also affects your respiratory system and your cardiovascular system. Um, it causes difficulty breathing because your respiratory muscles are being affected by it. Um, your cardiac muscle, your heart, also is affected, causing abnormal heart rhythms and things such as that. And as you can see in this chart on the left, there's a few more signs and symptoms that I've pulled from the Mayo Clinic. Um, so, yeah, moving on, we'll talk about muscular dystrophy and exercise. Now, all the research that I've found, and through personal experience with my cousin, I've noticed that exercise is more prevalent in the earlier stages when the children are young and first diagnosed, because they are able to still perform at an average rate. They're still able to walk. They're still able to do things that you and I would do in normal exercise uh, sessions and workouts in the gym. So when they get to the later stages of the disease, when they start to hit puberty and everything, like I said, they're walking and their ability to move and be as mobile as they were is compromised, and therefore they're not able to really perform at the normal level that we would. But with that saying, um, in the earlier stages, as you can see, exercise helps delay the onset and severity. It kind of prolongs the ability to have all the critical motor skills that the average human being has. Um, when they do get to the later stages of the disease and they're getting towards puberty, or excuse me, at puberty, they should avoid very strenuous activity. Um, and this is due to the fact that dystrophin, like I said, is able to keep the muscle's integrity. And when the muscle is torn from training, um, it's able to repair it. But in people and patients with muscular dystrophy, there is very little repair after the muscle has been torn and has been worked out, essentially. Um, so specific strenuous activities, you should stay away from, as well as any type of eccentric or muscle lengthening exercises, because they are have been found to cause more extreme damage than um, the full eccentric concentric muscle contraction. And like I said here, the muscle repair is very little to non-existent after the disease progresses. Um, and as stated earlier as well, it impacts the cardiovascular and respiratory health. So that's another factor that you have to be careful of when exercising with a client with muscular dystrophy. They're not able to go to their maximum potential for their age, body weight range, which is very unfortunate. But there's still ways to tailor it back a little, which we'll get into later with a specific exercise prescription I've developed. Um, and like I said, submaximal aerobic activity is probably the best for them to delay the onset of the disease. And when the disease is more present in the patient's body, to kind of um, manage and maintain without going overboard. Next, we'll move on to some pharmaceutical drugs and aids that aid in the treatment of Duchenne's muscular dystrophy and Becker's muscular dystrophy. Through some research, I found that corticosteroids, which are anti-inflammatory medications and drugs, such as prednisone and influenza, they help the inflammation, because when the muscles are torn down and stuff like that, and they're not able to rebuild, there's a lot more inflammation. The body isn't able to rid of the muscles of inflammation as easy with this disease, and because of that, it's found that anti-inflammatory drugs tend to help the symptoms a little bit. It's not a cure, it's not a very strong treatment, and it doesn't really prolong the effects as much, but it's kind of just like a maintenance drug that can ease pain and symptoms in these clients and patients. Now, what I did find was Exondys 51 and Translarna are rather new drugs that came about. I believe it was 2016. They started to find that these drugs actually help produce more dystrophin in the cells. Um, so what happens, back to the DMD gene on the X chromosome? What happens is there's a stop signal that the body chooses to have happen to it with the mutation. The mutation causes a stop signal in the production um, of dystrophin, and when that happens, that's why there's not a lot of dystrophin in the muscle, and the domino effect that we've been talking about. The Exondys 51 and Translarna actually are able to skip over that mutation and that stop signal slightly and kind of rev the body up more to produce more dystrophin. Um, and this has been found to increase the person with muscular dystrophy's quality of life by about 13% success rate. So again, they're relatively new drugs, and I'm sure that in the near future they will find uh, strains and forms of these drugs that they can combine with other things to maybe uh, delay the effects of the disease even more, and maybe even reverse the disease in a whole as a whole. So I have this case study. I have this male. He's age 7. He's about 4 foot 10 inches. Weighs 80 pounds. He's got his BMI of 19. His resting heart rate's pretty high due to the fact that he's a younger child, and also he's starting to feel the effects of the disease by the respiratory system kind of shutting down, not to the full extent of shutting down, but kind of tailoring back its capabilities and whatnot. And his blood pressure, average. It's okay um, for a normal person, but it's somewhat higher for a child. He was diagnosed recently with Duchenne muscular dystrophy, similar to the muscular dystrophy that my cousin was diagnosed with, and around the same time he was diagnosed. Um, and his goals coming in to see me were to prolong the ability to walk because he understands and has come to terms, him and his family have come to terms that the disease will progress, and they know the final outcome of being in a wheelchair and having to kind of tailor their lives to that new um, that new lifestyle, I guess. So he wanted to prolong his ability to walk and delay the negative immobilization effects of the disease. So for that, I gave him a standard 6 minute walk test to see how he fared with the aerobic capacity and strain that he would experience from that test. So with all this information and all this being said, I have have created an exercise prescription for him um, of starting with resistance training about 2 to 3 times per week at an intensity of 3 to 5 on a 0 to 10 scale of difficulty. I'd like him to do at least 4 to 6 exercises with 2 to 3 sets and 12 to 15 reps. The best way to delay this disease is to have high repetitions more than heavier weight. You want higher repetitions, lower weight, to kind of just build that muscle endurance and continue to um, prolong the the effects of the muscles atrophying and wearing away. And going along with the higher repetitions, we want to use free weights and body weight. We don't want anything too structured, such as like a barbell bench press, where you're gonna see the um, the client in a more linear motion. We want more range of motion and more muscles active in each exercise that they do. In terms of aerobic exercises, we'll have him do more 3 to 5 days per week with to kind of maintain the integrity of his cardiovascular and heart health. Um, Again, 3 to 5 on a 0 to 10 scale, 30 to 60 minutes without reaching exhaustion, and the best way to do that is swimming. Now, with flexibility, we have 5 to 7 days per week because this is very important for keeping the muscles lengthened, strong, and healthy as long as we can. Obviously, intensity stretch to slight discomfort, 15 to 30 seconds per stretch, and passive and active stretching is probably the best way to go about that. So, with all that being said, like to thank you for watching, and I hope you learned as much as you could about muscular dystrophy. Thank you.